Thank you very much, Chantal. Thank you for your nice introduction. Also, let me thank Abbott for organizing this symposium that gave us the opportunity to really look into what is the current revolution. You were referring to a revolution of the use of the CGM and how the CGM is going to impact our way to manage diabetes. And as has been already said, I will be discussing the potential of CGM for people with type 2 diabetes. These are my disclosure. But when it comes to the discussing of type 2 diabetes, I think that it's important to try to remind that type 2 diabetes has a very specific behavior over the time. This is a very well-known representation of what is the natural history of type 2 diabetes, and really depicts how type 2 diabetes is a progressive condition, characterized by progressive increase in glucose levels, both fasting and postprandial, throughout the day, due to the progressive failure of the beta cell function in the face of an increase and progressive increasing demand of insulin secretion due to the coexistence of insulin resistance. So what we try to do for people with type 2 diabetes is try to cope with this progressive feature of the nature of the disease, and this calls for the need of a progressive intensification of the treatment. So what happens normally on, let's say, in general speaking, in the treatment of type 2 diabetes is that from the time when we make the diagnosis, different therapeutic options are put at work. Initially is physical activity and dieting, of course, and then is oral agents, non-insulin agents, and then is basal insulin, and then is multiple daily insulin injection. There has been a new formulation, a new opportunity for treatment for these people, but also there are new opportunities for monitoring glucose. And Chantal already mentioned that CGM and continuous glucose monitoring is really revolutionizing the way we manage diabetes. So what is important to do is to really reflect on what is the potential of continuous glucose monitoring for all these phases of the natural history of diabetes. If you look at the top of this ranking, is basal bolus insulin. That very much reminds us about the multiple daily injections that are commonly used already in a lot of people with type 1 diabetes, and we know what is the impact of the continuous glucose monitoring in type 1 diabetes. But also we have learned that similar results and beneficial effects that can be proven in people with type 2 diabetes on multiple daily insulin injection. This is an example. This is a small randomized clinical trial showing how over a period of 24 weeks, it is possible to achieve in a larger percentage of people a reduction in A1C greater than 0.5% or 1%. And if you look at the size of these columns, you can appreciate that the use of the continuous glucose monitoring, shown here in the magenta color, is at least twice as much the percentage of the people able to achieve that A1C reduction with the traditional home glucose monitoring. So it's a significant improvement, but the vast majority of people with type 2 diabetes, fortunately enough, are not on multiple daily insulin injection. What is more common in people with type 2 diabetes is actually a basal insulin treatment. And for basal insulin treatment, also there are reports showing that the continuous glucose monitoring is indeed associated with an improvement in the glycemic control. Here's indicated by a significant reduction in the A1C, but also a concomitant, as expected, increase in the time in range. Now, this is a retrospective analysis, but all these data have been recently confirmed in a much larger number of observations, as has been derived from the Swedish registry, encompassing something like 5,000 people with type 2 diabetes, split in people with on multiple daily insulin injection or basal insulin, and again, subgroup on the basis of the initial baseline A1C. And what you can appreciate here is that irrespective, if you do consider that the total population or the people with multiple daily insulin injection or basal insulin injection below or above an A1C of 5.7%, 7.5%, there is a significant reduction in A1C after the initial 6 months, but also what is more important is that the reduction is maintained throughout the subsequent time. So at the end of the 2 year, there was still a significant 0.3, 0.4% reduction in A1C in these people using the CGM. It is basal insulin, as I said, but you know what is also interesting about this report here that has been published in the Betologia is not just the implication in terms of the glycemic control, but also the implication in terms of the risk the people with type 2 diabetes are exposed to. In this large population, it was possible to analyze what is the rate of hospitalization for a number of different causes. And here is the summary. And what is being reported here is that the whole population of type 2 diabetic individuals that have been included in this analysis, there was a significant reduction in the relative risk of hospitalization for hypoglycemia of 57%. That was also associated with a quite large reduction in the risk for admission to hospital because of acute myocardial infarction, stroke, and hypoglycemia and acute myocardial infarction and stroke for people MDI, and also with a report for reduction in hospitalization for heart failure in people on basal insulin. And this very much, reflects data that have been generated by Bruno Guerci and colleagues in France, suggesting that the use of the CGM is indeed associated with a reduction in the rate of hospitalization for a number of acute conditions. So basal insulin and insulin treatment by and large is, when used in combination with a CGM, is associated with a significant improvement in glycemic control. But I'd really like to draw your attention on this slide here, because if you look at these two panels here, they do not look very much different. There is, however, a difference here, which is important, because this panel here refers to people on basal insulin using CGM, while this one here refers to people that are not using insulin, but using other different glucose-lowering agents. And you can appreciate that the degree of improvement, the degree of reduction of A1C that has been obtained in people on insulin is not very much different. Actually, it tends to be slightly higher in people who are not using insulin. Again, these are retrospective data, but these data have been confirmed by proper randomized clinical trial, as the one that has been performed a few years ago in people who are not treated with insulin, but using oral agents. And shown here in this small group of individuals, a total of 100 people, that have been randomized to continuous glucose monitoring or the standard monitoring of glucose. And you can appreciate here what is the effect at the end of the initial 12-week of using the device, showing this nice reduction and greater reduction in A1C in people that have been using the continuous glucose monitoring. But what really, at least to me, looks even more interesting is not this initial reduction in A1C, but actually the fact that once the treatment, once the monitoring was stopped, the people who have been using continuous glucose monitoring still retain a maintenance of the improved glycemic control. And this has an implication, or at least may suggest that knowing better what happened, what occurs through the day in terms of the glucose control, in terms of the glucose variation throughout the day, generate a sort of a biofeedback that is training the people to really adjust their behavior, physical activity, dieting, and so on, that allow them to manage in a much more proper manner their condition. And this has been reinforced by the observation that when the people are taught how to use the information derived from the CGM by applying a sort of educational algorithm, as has been done here in this Korean study, where the Seoul algorithm, which is an algorithm that really gives suggestion in terms of what is the changes in the postprandial glucose concentration with respect to which food have to be chosen, this, again, was associated with a significant improvement in glycemic control. So the CGM in type 2 diabetes, even in people that are not treated with insulin, may be a sort of educational tool. It can be a tool that really can generate a positive biofeedback. And this has been also proven or suggested and supported by other data, by other results for non-insulin treatment, and I'm referring to the use of the very commonly used nowadays GLP-1 receptor agonist. Here is the data. So this is a general population. You can see here it's 1,400 people with type 2 diabetes that have been initiated on GLP-1 receptor agonists, and you can see the significant improvement associated with the use of the GLP-1 receptor agonist. But I'd like to draw your attention here, because here you can compare what is the degree of improvement in glycemic control by using GLP-1 receptor agonists, but also what is the added value of monitoring the glucose for drugs that are not associated with risk of hypoglycemia, like the GLP-1 receptor agonist. And you can see that in both cases there was a significant improvement in glycemic control as expected, but the use of the CGM was also associated with an extra, with an added 0.3, 0.4 point A1C reduction. So it is not just the pharmacological action of the glucose-lowering agent, but also is a combination of that action with a better management of the glycemic control. So if that is the case, and if really the CGM can generate a sort of a biofeedback, you can also expect that to be effective in terms of modulating the physical diet, the physical activity, and the diet of people with diabetes. Not much data is available with respect to this. There is some data. I'm just going to provide you with just a suggestion, actually a report from people, in this case, people with type 1 diabetes, that have been requested, that have been asked to which extent knowing what is the glucose profile throughout the day has affected that behavior with respect to their feeding or their change in the physical activity or the change in their diet habits. And just to make a long story short, what has been the response here is 90% of this population here claim that they felt to experience a healthier lifestyle with the use of the CGM. 47% reported being more likely to go for a walk or do physical activity if they saw a rise in their blood glucose. So the physical activity is now really entering the arena with a therapeutical goal. And 87% felt that they modified their food choice based on the CGM use. So again, knowing what is the changes in the glucose concentration with respect to the day life activity and day life diet and food consumption can improve the management of diabetes, and with that the improvement in the overall glycemic control. And also there is some potential for people with type 2 diabetes at the time of the diagnosis. This is just an example. What has been done here by Rumiana Dimova was to evaluate in a very precise manner the glucose profile using the CGM in people under very well-controlled diet and physical activity to reduce all the different variables, and then to combine or to compare what is the relationship between the coefficient of variation, the variability of glucose in these pre-diabetic individuals and the two major pathogenetic mechanisms of type 2 diabetes, that is insulin resistance and insulin action, here represented by two typical proxy for evaluating the beta cell function and the insulin sensitivity. And what you can see here is that there is quite an interesting relationship between the coefficient of variation or the standard deviation of the glucose level throughout the day as measured by continuous glucose monitoring and the characteristic of the pathogenetic background of these individuals. Now, these are very raw data, but just recently there has been a paper published on Nature Medicine, how this data, the data generated and collected through continuous glucose monitoring, has been elaborated through machine learning, applying artificial intelligence to really try to identify features and blueprints of people with diabetes, with type 2 diabetes, that may in the future provide a better guidance for initial treatment or for definition of the characteristic for favoring then personalized, if not precision medicine. So there are multiple situations, multiple conditions where we can see the continuous glucose monitoring used in type 2 diabetes. You can see here, and once again, in all the different stages that I try to highlight. I have to admit that for newly diagnosed diabetes, maybe just for the effect on diet and physical activity, we probably need more data, and there will be more data generated in the future. But I think that if you do consider people that are actively treated with the glucose-lowering agents, there is already a wealth of information supporting the use of the CGM. And this has been actually done in a very accurate meta-analysis that has been published in the Methodologia last year. And it really points out how people on insulin or not on insulin do have a significant improvement in glycemic control, but also highlighted how people without an insulin treatment also had a significant improvement in glycemic control. And also when you take into consideration people without with glucose-lowering agents other than insulin, still there is a significant reduction in A1C. But what I think is very interesting about this meta-analysis here is that if you do compare what is the average improvement in A1C for the different subgroups of people with type 2 diabetes, you can appreciate that it's the same degree of improvement. And this has been highlighted by the chi-square, which is zero, suggesting that there is no P of interaction. In other words, that what is the benefits that is brought about by the use of continuous glucose monitoring in people with type 2 diabetes with insulin treatment and without insulin treatment is very much the same. So providing an opportunity for really improving glycemic control in a vast majority of people with the type 2 diabetes. And because of all this current evidence, a group of people came together trying to analyze and to highlight what is known and what is still required to be explored in a better manner. And recommendations have been proposed to the community, to our colleagues. And these recommendations for the use of CGM in type 2 diabetes are summarized in this slide here. So what we have done was to highlight what could be the potential of CGM in all individuals, in the whole population of people with type 2 diabetes, at 3 different segments of their natural history: a diagnosis through the stable phase of their disease, and in the long duration, in people with long duration disease, or if you want, in elderly people. And now what we have been suggesting is that the diagnosis, the glucose monitoring may allow to establish a better profile of these people that maybe in the future may elaborate and may become even more interesting and effective, and also to evaluate the immediate response to any treatment that we are going to put at work. For people with a stable diabetes, it will continuous glucose monitoring may allow to uncover hidden glycemic abnormalities, included hidden hypoglycemic events, to allow a more proper adjustment of the therapy, and to manage the glycemic goal, to differentiating the different metrics to bring the overall glucose control to a better level. And for people with a long duration of disease, particularly the elderly one, the continuous glucose monitoring can be very effective in intensifying the treatment, but also in de-intensify the treatment, so providing a better safety along with a better outcome in these individuals. Then the second group is represented by people who are treated with insulin, and I think that's very much like to what has been the recommendation for people with type 1 diabetes. In these individuals, the CGM is very much indicated to support the self-management and to avoid hypoglycemia, reduce hyperglycemia, limit glycemic variability, but let me translate that into reducing the risk of developing complication. And finally, for the non-insulin treated type 2 diabetic individuals, it may be very, very helpful in reinforcing education. As I mentioned to you, it can be a sort of biofeedback tool that can be used. And also this supports the use for intermittent use of the continuous glucose monitoring, which may not really require to be all the way, but it can be used in order given specific time to, again, to reinforce the self-management. And then it may also allow monitoring of adherence to treatment and to improve the appropriateness of the change of the treatment. So my take-home messages are here. And I think, that for type 2 diabetes, CGM may be very important because it may allow to engage people in the management of their condition, to evaluate the treatment responses and achievement of goals, adjust therapy as needed, to more accurately evaluate the risk of micro and macrovascular complications, reinforce education, and improve self-management skills in people with diabetes. But Chantal, in order for this to be effective, I agree with you, we need to have accurate measurements and reliable measurements of the CGM. Thank you very much.
Thank you. They want me to stand closer to you. Okay, good. So there's a few questions. So one question before you came to it was mainly, should all people with type 2 diabetes then be offered the sensor?
I mean, I think that the sensor is a clinical opportunity that should be considered and offered to people with type 2 diabetes. This, as I was referring in my final words, it doesn't mean that everybody has to wear continuously. Yeah. It depends. For people on insulin, yes, I would say so. For people that are initiated on a treatment, it can be intermittent to really monitor and to really allow them to become more able to really manage their treatment.
So in people not on insulin, it looks more like an educational tool? It makes people see what exercise does?
There was a philosopher saying that, we used to say, know yourself. And if you know yourself, you probably can do whatever adjustment is needed. So I think, yes, it's a sort of educational tool. It really allows the people to realize the importance of what is the effectiveness of the treatment that is being put at work. So it can be very much motivational for them in order to really try to achieve what they need to achieve.
In your review of literature, did you find any cost-effectiveness studies or economic analysis?
There are some cost-effective analysis. Actually, we did a paper that has been published last year, where we did a cost-effective analysis in people with type 2 diabetes on basal insulin treatment, and proving that at least for what is the condition that we have been analyzing, and that was within the health system of Italy, which may not directly apply to all the different countries, but in our system, it was cost-effective.
In all people with type 2 or just
the analysis that we did was in people type 2 diabetes on basal insulin.
Okay. Then a question related. Any insights on intermittent CGM use for those at risk of T1?
Sorry, say it again?
Of any use of any insights into the intermittent CGM use for those at risk of T2D?
Oh, okay. So this is, before diabetes develops. No, I'm not aware of any specific study that have been looking at that, but there is, as I was sort of alluding to, for the newly pre-diabetic individuals, I think that we're going to gather more data, particularly on the potential for the CGM to be predictive or more predictive for development of type 2 diabetes, or for identify specific feature and phenotypes that may be associated with a risk of developing for diabetes or risk of developing complication, or for guiding in a more precise manner the treatment.
Yeah, and you alluded in one of your slides also to the advent of AI into these CGM systems. How do you see this evolving with also, lifestyle advice also in, when you see things happening, or how?
Yeah, I think there are multiple ways where the AI or the machine learning can really generate a better information and more precision medicine. This can be because of analyzing all the data in terms of glucose profiling together with other characteristics of the individuals, including identification of specific response to the environment, but also in adding or combining suggestion and app that could really provide a more educated advice to people to adjust the therapy or adjust the lifestyle.
Yeah. And then there's a question actually addressed to me, because I said,
I'm not going to answer that.
Yeah, I will answer it. But so, because I made the statement that there should also be evaluation of the reliability of the sensors during changes. And so the person says, actually there is this physiological delay between the blood and the glucose under the skin. So how could this be solved? Probably also by AI, probably also by the modeling that we can address this lag phase. It's already there in the algorithms where they try to deal with this delay, but I also foresee there that AI may be a big change. Final question, and then I let you go. Should we have different glucometric targets in people with type 2 diabetes? In other words, is time in range 70 to 180, 70% enough? Or should we go to time in tight range, 70 to 140, or the new thing, 63 to 140, and then have another percent there? Your opinion.
You know, Chantal, I think that we are facing now opportunities, therapeutic opportunities that may give us the chance to really approach very much normal glucose range without really increasing the risk of hypoglycemia. And if that is the case, we probably need to go for a very tight timing range. Could be the thing, or maybe the next thing again in the future.
Ting. Okay.
Ting.
Thank you very much.
Sing is another thing.
Oh yeah. Okay. Thank you very much, Stefano.
Thank you.